রেসপেক্টেড ফিজিশিয়ানস অ্যান্ড স্টুডেন্টস, সবাইকে আমাদের বিডি ফিজিশিয়ানস কর্তৃক আয়োজিত ইসিজি সেশনের থার্ড পার্টে স্বাগতম। আজকের টপিক ইসিজি অফ অ্যাকুয়েট মায়োকার্ডিয়াল ইনফ্রাকশন অ্যান্ড আদার কজেস অফ এসটি এলিভেশন। আমাদের মাঝে যথারীতি স্পিকার হিসাবে আজকে উপস্থিত হয়েছেন প্রখ্যাত ইলেকট্রোফিজিওলজিস্ট ডক্টর রফিক আহমেদ স্যার। ডক্টর রফিক আহমেদ স্যার কনসালটেন্ট কার্ডিয়াক ইলেকট্রোফিজিওলজিস্ট, মেডিস্টার হার্ট অ্যান্ড ভাস্কুলার ইনস্টিটিউট, বেলটিমোর, ইউএসএ। আমাদের সাথে চেয়ারপারসন হিসেবে যথারীতি আজকে উপস্থিত আছেন প্রফেসর মাহমুদ হাসান স্যার। প্রফেসর মাহমুদ হাসান স্যার এক্স ভাইস চ্যান্সেলর বিএসএমএমইউ এবং এক্স প্রেসিডেন্ট বাংলাদেশ মেডিকেল অ্যাসোসিয়েশন। আমি প্রফেসর মাহমুদ হাসান স্যারকে আজকে সেশনটি শুরু করার জন্য আহ্বান জানাচ্ছি।
ধন্যবাদ এহসানুজ্জামান সাহেব এবং ধন্যবাদ বিডি ফিজিশিয়ানস, ধন্যবাদ ডক্টর রফিক আহমেদ সাহেব। আমি রফিক আহমেদ সাহেবের সঙ্গে আপনারা বিগত 2 সেশন ছিলেন এবং আপনারা আমি অত্যন্ত আশাবাদী যে অনেক কিছু শিখতে পেরেছেন, কারণ অত্যন্ত প্রাঞ্জলভাবে এবং উদাহরণ সহ রফিক আহমদ সাহেব আপনাদেরকে ইসিজি দেখিয়ে দিচ্ছেন। ইসিজি একটা অত্যন্ত গুরুত্বপূর্ণ টুল চিকিৎসার জন্য, শুধু কার্ডিওলজিস্ট নয়, শুধু জেনারেল ফিজিশিয়ান নয়, সবারই ইসিজি জানা প্রয়োজন, বেসিক ইসিজিটা জানা প্রয়োজন। তো রফিক আহমদ সাহেব সম্পর্কে আপনারা আগেও শুনেছেন, উনি অত্যন্ত প্রথিতযশা এবং অত্যন্ত অভিজ্ঞ কার্ডিওলজিস্ট, যিনি বহুদিন ধরে এই কাজ করছেন এবং ইলেকট্রোফিজিওলজিতে উনি একজন ওয়ার্ল্ড রিনাউন্ড বিশেষজ্ঞ। তো আমরা আর দেরি না করে রফিক আহমদ সাহেবকে অনুরোধ করব যে আপনি অনুগ্রহ করে শুরু করুন। ধন্যবাদ।
Good morning. Assalamu alaikum, Kawaike. Today we're going to talk about acute myocardial infarction, but basic thing is that with acute myocardial infarction, there is ST elevation, and there are a few other conditions which we encounter can also cause similar ST segment change. So I think we're going to keep the format the way we did it, and it would be nice if we can get volunteers. So this is basic ECG. We have talked about it. If we look at the ECG recording, there's a P wave, then there is a PR segment, which is isoelectric, and then Qrs complex, then followed by ST segment, T wave, and then sometimes we can see E waves. And the measurements that we measure is a PR interval from the beginning of the P wave to the beginning of the Qrs complex. This is a very common measurement, but sometimes people make mistake because it's called PR and people will try to measure it from P to R wave. But as a matter of fact, reality, it is PQ complex. And then QRS duration, QT interval, those. And if we look at again and expanded, what is the ST segment? ST segment is this portion from the end of the QRS complex, which we call J point, to the beginning of the T wave. Ideally, it should be a flat line like this and similar level as the PR and the TP segment, but sometimes you can see some distortion here. And then we have the T wave. And if we superimpose with the electrical action potential, if you look at this action potential, this is a phase 1, phase 0, phase 1, phase 2. The ST segment is phase 2 of the action potential, and the T wave is the phase 3, and then phase 4, of course, is the part where it recovers. Anybody to do this ECG? I want one volunteer.
Dr. Mahabuba, please. Dr. Mahabuba.
Everybody?
Dr. Mahabuba, please. Dr. Mahabuba, can you hear?
Assalamu alaikum, sir. Yes, sir.
I'll tell you the heart rate 84, 84 beats per minute. And can you do the rest for me, please?
Yes, sir. Heart rate is
84.
84 beats per
Yes.
minute. Yes, sir. Here, sir, sinus rhythm.
Okay.
Sir, P wave present. P wave
Okay.
present lead to. Sir, here P wave, sir, is slight biphasic lead to. And sir,
Why did you say it is sinus rhythm?
sir, it's regular. Sir,
Yes,
sinus rhythm
there is
plus
a P wave.
regular in. Yes,
Okay.
sir. P of lead to and sir, lead. Answer here, PR interval,
Yes.
sir, is within normal, sir.
No,
Three
how many
small
boxes?
square, 0. Sir,
One,
sir, 1, sir, 2, sir, 0.12 second.
Yeah. Okay. Sure.
Sir,
Correct. And the
sir.
QRS duration?
Then, sir, QRS duration is within, sir, normal.
No, how many boxes?
Within, sir, here, sir, QRS interval, sir,
2 boxes, right?
sir, two box, 2 small box, sir.
So 80 millisecond. And then I'll give you the QT interval. QT interval is about 340 millisecond. Now, can you tell me about
340,
the?
sir. 340.
Yeah. Can you tell me about the ST segment?
Sir, ST segment, sir, is sir, smiled. Sir, it's just a normal, sir.
Good. Yes, ST segment normal. Remember, even though it's a ST segment elevation session, doesn't mean that all of them will have that. ST segment is normal. And how about the T wave?
Sir, T wave is, sir, sir, mild elevated. Sir, in the lead, sir, V2, V3, V4, sir, V5. Sir, mild elevated, sir.
Yes, it may look, but it's not. And so, because we'll call it elevated if it were really big. It's not big. So this is fairly normal size. So what is your final conclusion?
Sir, it's, sir, final conclusion normal ECG, sir.
Normal ECG, yes. One thing that I always remind people that when you see P wave before each Qrs complex, that's an atrial rhythm, and then P wave is upright in lead 2, 3 AVF. That makes it sinus. So you are absolutely right. So please stay with me. And I'm going to give there are the 2 changes that we can give. We can ST elevation, ST depression. So how about this ECG? Mahbub again. Just look at lead V2. What do you think of the ST segment? This is a 23-year-old male without any other problem. PR interval is normal, heart rate is normal, but I want a comment on lead V2. What do you think of the ST segment?
Sir, in test lead, we know, sir, ST segment elevation, sir, তখনই বলবো যখন স্যার more than 2 small square হবে, sir. তো স্যার এখানে
yes, is it elevated?
Yes, sir. জি স্যার। So এখানে স্যার 3 to 4 small square দেখা যাচ্ছে, স্যার।
Okay. So lead V2, there is ST elevation, right?
Yes,
and this, is it abnormal? So describe, first of all, whatever you see, you describe. Whether it's abnormal or normal, that's a different story. Now, this ST segment, so I did it. I enlarged it. If you look at the ECG, I draw a line and you can see the ST segment is elevated, right?
Yes.
That is a normal pattern. In transition lead means, you see the V1R, V2R is getting bigger and V3 is big, right? This is a transition zone. In the transition zone, you can see some ST elevation, which is normal. So please remember that. In V2, sometimes in V3, there is ST elevation, which is not. Other thing is that this is a concave ST segment. So that's the normal pattern. That's the normal variant, absolutely normal ECG. Again, another one, you can see there is in lead V2, there is some ST elevation, but that's the normal pattern. How about this one? I want somebody to do this ECG. The heart rate is 54 beats per minute. Anybody can comment on the ST segment? Yes, and can you ask somebody to do it?
Dr. Arafat.
Assalamu alaikum, sir.
Heart rate is 54 beats per minute. Rhythm?
Sir, rhythm is sir regular, as sir every Qrs complex is followed by P wave.
Preceded by P wave.
Sir, preceded by P wave, sir. Here, sir, the axis, there is left axis deviation, sir.
No, it's not left axis. I'll tell you why it is not left axis. That lead 1 is positive, right? So it's
Sir.
on the right side. AVF is positive, so it's on the bottom. So it is between 0 and 90 degrees. So normal axis.
Sir, right, sir.
Yeah.
Normal axis, sir.
Good.
And sir, PR interval is around, sir, 2.5 small square. That is 100 millisecond around.
Little short, yes.
Yes, sir. Around 100 milliseconds, sir. A bit short, sir.
And the QRS duration?
QRS duration is 2 small square. That is 80 milliseconds, sir.
Normal.
And sir, normal, sir. And QT is around, sir, 3, 5, and 8 small square.
box.
That is 320 milliseconds, sir.
Well, I think if you look at lead V2, it's almost 2 big box. It's close to 400 milliseconds, which is still normal.
Sir. Normal,
How
sir.
about the ST segment? What do you think of the ST segment?
Sir, ST segment is a bit elevated in the lead 1, 2, 3, and 4, 5, 6 also, sir. I think J point elevation, sir.
Okay, so it's elevated in lead 1, right?
Sir, elevated in lead, sir, V1, V6 also elevated, sir, and lead 2 there is lead 3 and 2 and lead 3 there is slight elevation also, sir.
And then lead AVF, right? So, okay,
Yes, sir.
fine. So stay with me. So what I have done, I have put a line on it. Lead 1, maybe a little bit, but lead 2 clearly elevated, right?
Sir, right, sir.
And then lead 3 is elevated, lead AVF. So, and then V1 to V6, all elevated. What do you think of this?
Sir, I think it is a normal variant, J point elevation, sir, due to early repolarization, sir.
Yes. So this is a young man, a 19-year-old male without any symptom. And so this is early repolarization. Stay with me. So what early repolarization is this? This is concave ST elevation, and there will be a notching of the QRS, splitting on notching. And there is one formula. Look at this one. So these are the patterns that you can see early repolarization, like this one. There can be J wave, it can be splitting. And the more important thing is that this will be asymptomatic young individuals. So this is not an abnormal finding. This is within normal limit. However, if I get this ECG in a 50-year-old, that can be confusing. And then sometimes you can say, if it is a young person, you can more or less conclusively say it's an early repolarization. But if it's the older person, then you can also have to say, cannot rule out pericarditis or ischemia. So, because I don't know if I don't know the history of the patient. Thank you.
Is there any relationship with hypothermia and J wave, sir?
Yes. Well, that's hypothermia can cause Osborne wave or this similar, you see, like this ECG, you can see similar kind of wave in hypothermia also. But then the clinical scenario of the patient will tell you if the patient is hypothermic. This is another example of a patient with ST elevation. You can see this sliding of the terminal portion of the Qrs complex with ST elevation. This is again early repolarization. So these are the things. There is one interesting finding that you can see this J point elevation. Then if you look at the ST elevation and the T wave, the ratio, if you calculate the ratio, it should be less than 25%. So ST elevation was 1 millimeter.
Sir.
T wave in the same lead is 6 millimeter, and if we divide 1 by 6, it's less than 25%. And that will be suggestive of early repolarization as opposed to something else. Now, the other condition that is, as we can see ST elevation, left bundle branch block. In lead V1, V2, sometimes V3, you can see ST elevation. That's the general normal pattern. And you can see the similar ST elevation in patients with pacemaker. So what happens with ST elevation? In transmural myocardial infarction, you all know there is ST elevation. What happens actually at the resting phase, when you record it, this ischemic myocardium is depolarized and rest are not. So the baseline comes down. When the whole myocardium gets depolarized, baseline goes to what it should be. And then again, when it is repolarized, it comes back to this ischemic state. So what we call elevation, actually, the baseline has shifted down, and then it looks like ST elevation. And the reverse thing, and subendocardial ischemia, on the other hand, if there is ischemia in the subendocardial region, the baseline goes up. And then once the whole tissue is depolarized, the baseline goes to isoelectric line, and that's why the ST segment looks depressed. Now, different kind of ST segment ischemia. So if this is a normal ECG, when the patient initially becomes ischemic, there is the T wave becomes tall and symmetrical and peaked. We call it hyperacute T wave. Please remember, we can see tall T wave also in hyperkalemia, but they don't have a broad base. They'll have a narrow base. And then second stage, you can see the ST elevation without distortion of the terminal portion of the Qrs complex. And then finally, you will see this distortion of the terminal portion. So this different level of ischemia, it depends on where the patient you find. So immediately after patient starts having chest pain or there is coronary occlusion, you can see this kind of change, and then it progresses to further change. And there are different types of ST segment elevation. You can have convex ST elevation, we can have curved ST elevation, we can have a plateau horizontal, or you can have a plateau like curved, a little curved, and then we can have upsloping. It should not be concave, and then of course the J point, the whole J point can go up with acute ST elevation. And you see, even though ischemic ECG is not, acute ischemia is not concave, sometimes we can see this concave, little bit of concavity in the ST segment. Anybody? Heart rate is 128. I need one volunteer to tell me about this ECG.
আরাফাত সাহেব, আপনি আগেরটা বলছেন। ডক্টর আরাফাত, এবার না নেক্সট। এনিওয়ান এক্সেপ্ট ডক্টর আরাফাত? ডক্টর মাইসুম সোবাহান, আপনি বলতে পারেন কিন্তু বই পাবেন না। মাহমুদুল হাসান, আপনি ওকে? ডক্টর মাহমুদুল হাসান,
গুড।
মাহমুদুল হাসান, মাহমুদুল হাসান আপনি, হ্যাঁ বলেন।
স্যার হার্ট রেট আপনি বলেছেন স্যার।
Yes, 128. I also measured the PR interval is 160 millisecond. QRS duration 76 millisecond. Question is, please tell me about the QRS complex and the ST segment. What did you say?
বলতে পারছি না, তবে স্যার এখানে ওই দিন নরমাল মিটার আছে মনে হচ্ছে স্যার।
কোনটা কি জিনিস?
হতে পারে QRS স্যার কমপ্লেক্স।
No, I have told you that the QRS duration 76 minutes because there is no grid. I'm not. I want your comment on the QRS complex morphology and the ST segment.
ST segment is elevated in lead V3, V4,
Okay.
V5, and
V6 also,
V6.
right? How about V2?
V2 তে হচ্ছে
Okay,
V2,
and what
V3,
else?
V4,
Yeah.
V5.
And what else?
So it is concave type of ST elevation, sir.
Yes. And how about the QRS here?
QRS.
You see, lead V1, V2, you should have seen bigger R wave. You don't. There is no R wave, V1, V2, V3, V4. Why is that? So there is a Q wave, right?
Yes, sir.
Okay. So basically, so what is your diagnosis of this one?
Sir, ST elevated, enterocerebral ST elevated myocardial infarction.
Yes. And so this one, if you look at it, the patient already has developed Q wave. So probably it is already established acute myocardial infarction. So patient came a little late. Please stay with me. I'm going to follow up on this one. This is a little difficult. I'm not going to do this one. How about this one? Somebody?
নতুন কেউ?
I have given all
Dr. Mahim Ibrahim. Wait, Mahim Ibrahim, I'm bringing you as panelist. Okay, Dr. Mahim Ibrahim, please. Dr. Mahim Ibrahim, please.
Assalamu alaikum, sir.
Walaikum assalam.
So I have given you the heart rate. Heart rate is 117. PR interval is 146. QRS duration is 84. Right axis deviation, it says. So I need your comment on the ST segment and also about the right axis.
Thank you, sir. Sir, the ECG shows that it is sinus rhythm as in lead 2, 3 AVF.
Okay.
QRS is followed by P and it is upright in direction.
Yes, good.
And in lead 2, 3 AVF, there is also ST segment elevation, concave type of ST segment elevation.
Yeah.
And also in V1, V2, V3, V4, V5, and V6.
Yes, and what is this elevation like?
This is also concave type of ST segment elevation.
No, but this is convex. See?
Right, sir.
Convex ST elevation. One more thing. Why is this P wave inverted in lead 1?
Sir, as it is showing right axis deviation, and that is why.
But even if it is right axis, the P should not be inverted.
Right, sir.
Why is it inverted? So this is limb lead swap. By accident, it happened. So what is your diagnosis with the chest lead?
Sir, as there is ST segment elevation, convex type, and there is also deep Q wave.
Yes.
From V1 to V6, my diagnosis is it is acute extensive myocardial infarction.
No, where is the Q wave in V6? There is Q wave in lead V1. There is Q wave in lead V2. But you see in V3, there is a small R wave. If there is any R wave, it's not a Q wave. This is S wave. In V4, V5, V6, there is no Q wave, right?
Right, sir.
So, but you are right, acute anterolateral myocardial infarction. Question is, we have to look at this location. So please remember, lead 2, 3 AVF is the inferior surface of the heart, right?
Right, sir.
V1, V2, V3 is anterior. V5, V6 lateral. And this, can you tell me if it is in V1, V2, V3, which vessel is involved?
So it's right coronary artery, sir.
Okay, right coronary artery goes from the right side to the inferior surface, right?
Right, sir.
So it cannot be right coronary artery because the ST elevation mainly is in V4, V5, V6. The one that comes anteriorly, which is left anterior descending, why am I asking for vessel? You don't have to know the vessel, but just to look at the location on which vessel goes there. Okay, look at this. This is the angiogram of the same patient. Right coronary artery, looking from the front, is open, widely open. And then, if we look at the LAO view, this is the left anterior descending artery. It is subtotally occluded. And after stent placement. So I'm giving this picture so that to tell you that what ECG we see actually is accompanied by occlusion of the coronary arteries. Thank you.
Sir,
So,
Dr. Partho want to say something about this ECG. Okay, Dr.
Okay, go ahead.
Partho, floor is open for you.
Thank you, sir. Sir, it is not a technical dextrocardia. The AVR is upright in positive in lead and P is also inverted. Oil is not a technical dextrocardia.
Okay. The technical dextrocardia, you will call if the chest leads are all normal. See, because it's a biphasic in V1 and then upright in all the other chest leads. So it's only a limb lead swap because it's only in the limb lead changes. Okay. So why don't you do this ECG? Partho.
The rate is about.
No, I have given the rate here, 103 beats per minute, heart rate.
Rhythm is sinus, and
Okay.
there is ST division in lead 2, 3 AVA, and
Okay.
ST depression in 1 in AVL.
Yeah.
And there is
So which vessel do you think is involved?
right coronary artery.
Right coronary artery. So perfect. So let's look at this. So this is, again, I'm going to show this picture. Lead 2, 3 AVF represents inferior surface. The right coronary artery comes from this side and goes to the inferior surface. So it should be the right coronary artery. Angiogram, this is the left coronary artery. Looking from the right side, this is the left anterior descending artery. This is the circumflex. They are wide, both of them are wide open. And look at the right coronary artery. You see, there is nothing going on beyond this. And once they put the stent in, you can see the difference that the right coronary artery is totally open now. So total occlusion of the right coronary artery caused this acute myocardial infarction. Next person, please. Who will do it next?
Oh, okay,
So
Dr. Murad. Dr. Murad, let's try your luck.
Murad?
Okay, Dr. Afsana Rahman.
Assalamualaikum, sir.
Okay, Murad.
Murad?
Sir, after Murad, Dr. Afsana Rahman.
Good. Can you, as you cannot see the grid, because this ECG is from, in America, what happens once the ambulance is called, they will do a 12-beat ECG and they will transmit it to us wirelessly. And the grid doesn't come very well. So I have given you the heart rate is 81 beats per minute. PR interval is 170, QRS duration 90 to 97 degree plus 97 degree QRS axis. And then you do rest of the thing. What else is there? Is it a rhythm sinus or not sinus?
So rhythm is sinus rhythm. PWave is present, and it looks like sinus rhythm.
Why do you call it sinus?
Lead 2 and lead 3, there is a P wave present.
Yeah. But what else of the P wave? They are upright. P wave is upright in lead 2, 3 AVF. That makes it sinus.
Yes, sir.
And
Yes, sir.
what is this? What is this bit? That one I'm pointing.
So this is ST elevation.
No, what I want to know, this is PQRS, right? Can you see my arrow?
Yes, yes, sir. Yes, sir.
Okay, and then PQRS.
PQRS.
PQRS PQRS, but this is a little early. What is this? B?
This is difficult. This
It's a premature beat, right?
premature. So,
Because
but premature bit, there is white atypical. It is not atypical. Look like an other rhythm.
yes.
Or,
So what kind of premature beat is this?
it is the atrial pre-excitation.
Fantastic. Not pre-excited. You are absolutely right. You pointed out that the beat is premature, but it looks exactly like the other beat. So
Yes,
it must be a supraventricular. And look at, there is a P wave. So this is a supraventricular premature beat. Sinus rhythm with supraventricular premature beat. Now, tell me about the ST segments.
There is ST elevation in 3 AVF.
3 AVF.
And ST depression in 1, lead 1.
And AVF.
And others, it's look, others ST elevation is look like normal, except.
Okay, fine. What is your diagnosis?
And in although 3 and AVF is ST elevation, but not it's cover the territory of the right coronary artery or the inferior surface. And can we tell the inferior MI?
What is your diagnosis?
It's look bit difficult, sir.
No,
Okay,
but give me a diagnosis.
Sir,
You have to
Dr.
give
Afsar Rahman.
Sir,
Let's
Assalamu
give
alaikum,
her a
sir.
chance, sir. Dr. Afsar Rahman.
Sir, Assalamu alaikum.
Sam?
Sir, there is ST elevation in lead 3 and lead 3 and ST depression in lead 1. Sorry, ST elevation in lead 3 and AVF and ST depression in lead 1 and AVL.
What is your diagnosis?
My diagnosis is inferior lateral inferior MI with lateral ischemia.
Okay.
And local changes maybe.
Okay. So your diagnosis is, I think it is better to keep it simple. Because if you look at V5, V6, there is no, you can say reciprocal ST depression. So acute ST elevation in 2, 3 and AVF, so acute inferior myocardial infarction. Please remember that if I do not diagnose myocardial infarction, I am harming a patient. So it's very, very important to be able to tell. Sometimes you will not see ST elevation in all 3. You may see in only 2, like here, lead 2 didn't show it. Which vessel is involved, Afsana?
It looks like right coronary artery, sir.
Okay, so let's see if it is really right coronary artery. So same patient, when the patient arrived in our hospital, they still had ST elevation, but look at this. The difference is that now there is a little bit of terminal T inversion happening in this lead. And there is also in V6, there is some T inversion. So look at the vessels. So this is the right coronary artery. So there is the right coronary artery angiogram, then there is nothing after this. And once they put a stent in, you can see the vessel is open. So there is acute occlusion of the right coronary artery.
Exactly, sir.
Okay. Anybody else wants to do this one? This is a bad looking ECG, but very extensive. I'll do it myself. So if you look at extensive, really ST elevation in 2, 3 AVF, and then V4, V5, V6, actually V3, V4, and then ST depression in lead 1 AVL. So it looks like as if there is right coronary artery involved, and also there is ischemia in the LAD territory, including the circumflex. So, and the patient has sinus bradycardia. When you see inferior MI, you can develop sinus bradycardia. You can also develop 2-to-1 heart block. So please make sure when somebody has heart rate of 40 or 45, 50 with myocardial infarction, especially inferior myocardial infarction, think about 2-to-1 heart block. But this one is not, because it is slow and fast. It's probably sinus bradycardia. And if we look at the angiogram, that right coronary artery is totally occluded. After the stent has been placed, the right coronary artery is open. But the left also, if you look at LAD, it is tight ostial stenosis. So, but the culprit vessel was the right coronary artery. So what happens is when two vessels are involved, we usually stent the one that we consider was causing the clinical problem for this patient. So anybody, this is a little tricky ECG. I think it's good for the cardiologist, but can anybody wants to do this one?
Dr. Mahmudul Hassan, Dr. Maisim Sobahan, again Dr. Mahmudul Hassan. Do you like to interpret it?
Sir,
I've given the heart rate here, 103.
yes.
Sinus tachycardia, right?
Yes, sir.
And do we say anything else? What is this bit?
It seems like ectopic beat.
Ventricular ectopic.
Ectopic.
Yes, because it is wide, ventricular ectopic bit. Fine.
Yes, sir.
What else? Do you say anything else? ST segment?
ST segment, sir, depression bolbo, sir.
Where? One.
Lead 2, lead AVL.
AVL.
Then
and
V4.
Yes.
V5, V6.
V6. Yes. So what do you think? This is a patient who's having chest pain, 8-year-old.
Yes, sir.
So the ST segment depression is not really very remarkable, but if you look at it, there is some ST elevation in lead AVR. Can you see it?
Yes, sir.
Yes, sir.
And that, and also in lead V1.
Yes, sir.
And what is this? Do you know anything about this? This is if there is left main stenosis, you can see this finding. And it's important because otherwise the ECG doesn't look very bad. So the same patient, right coronary artery, he has a very small right coronary artery, and you see this is the left main. There's a tight stenosis of the left main. Now, for general practice, if somebody misses this, I will not blame them because it is such a subtle change. But we must remember the acute ST elevation with chest pain, especially new onset chest pain in lead 2, 3 AVF, that's inferior MI, lead V1, V2, V3, and entry MI, 1 AVL, V5, V6, lateral MI. We need to identify those ECGs. Please do not
sir,
make
I have a question, sir.
Yes.
Sir, can we say it non-ST elevated MI if patient has chest pain?
Yes. So if patient has chest pain, how will you say non-ST elevation MI? You have to have troponin.
Yes, sir.
So if the troponin is elevated and there is diffuse ST depression like this, then you can call it non-ST elevation micronym. But we as a cardiologist should be able to identify this AVR. If the AVR ST elevation was not there and there is diffuse ST depression, then you will call it non-ST elevation myocardial infarction. But you have to be a proof of myocardial infarction. That means you need to have troponin available.
Thank you, sir.
Sir, one question, please.
Yes.
Sir, is any significance of basal occlusion in if AVR is positive or ST elevation and other lead is normal?
Your question is just AVR is elevated, right?
Yes, sir. And if AVR is positive,
yes.
And
okay, I'll show you this. Okay, look at this one. This ECG again, there is ST depression in other leads. It is unlikely to find left and then, but there is ST elevation in lead AVR, lead V1. And lead AVR ST elevation is more than lead V1. And this is, please stay with me. So this is the first patient, same patient. Right coronary artery is big. But the left coronary artery, what the patient had is actually a tight stenosis of the LAD and circumflex both. And after stent, so it is, even though it was not left main, it is equivalent to left main. And so these are the findings of left main stenosis. Widespread horizontal ST depression, most prominent 1, 2, V4, V6, ST elevation in AVR more than 1 millimeter, ST elevation in AVR more than V1. So to answer your question, if there is no ST elevation in other lead, it is tough to call it left main. And it is probably not left main disease. I mean, even though we will catch that person. Did I answer your question?
I think yes, sir.
May I ask a question, sir?
Yes.
Sir, then what is the significance of ST elevation just in single lead, like AVR in AVR lead?
Well, in AVR, sometimes you can see minimal ST elevation, but if let's say somebody has no symptom at all, and there is no chest pain, and you just find minimal ST segment change in any lead, you will not call that significant, but this becomes significant in the presence of chest pain and ST depression in other leads to suspect left main stenosis.
Thank you, sir.
Okay. So this is another one. This is patient with left bundle. Left bundle becomes a problem because left bundle itself has ST elevation. But if there is more than 5 millimeter ST elevation with chest pain, then we usually call that patient is having an acute MI. So please remember, these are the criteria. If there is left bundle branch block, ST elevation 1 millimeter or more, concordant with QRS. What it means, concordant means, if the QRS is looking up and the ST is more than 1 millimeter elevated, like this one, then we call it myocardial infarction. ST depression 1 millimeter more in V1, V2, V3, if there is depression, or ST elevation 5 millimeter discordant. That means QRS looking down and ST elevation more than 5 millimeter, like lead V2, then we call it acute myocardial infarction in the setting of left bundle branch block. I'm going to skip these two ECGs. Just I'm going to look at we're just talking about Q wave. If you look at lead 2 here, there is a small Q wave, but here there is a small R, so it doesn't fulfill the Q wave criteria. But over here, there is a small R in V1, small R in V2, small R in V3, but V4 there is no R. So this is actually an old anterior infarct because it has already developed Q wave. And likewise, this one, there is a small R. So by definition, this is not a Q wave. This is S wave. But here again, there is small R wave in V1, V2, V3, but V4, there is no R wave at all. So that's a Q wave. And you can see that there is a Q wave in V5 and small Q wave in V6. So it's basically an lateral myocardial infarction and supported by a Q wave in lead 1 and AVL. Can somebody tell me about this QRS complex?
Dr. Rahimullah, can you try your luck? We want some fresh faces every day. Dr. Rahimullah? Sir, bhul hole sir mind korben na, don't worry. Sir chacchen keu bhul koruk.
No. Yes, like it's fine. I mean, you answered the question, I will discuss it. I mean, I make mistakes. Everybody. That's the way to learn.
আমি নতুন কারো কাছে শুনতে যাচ্ছি
অবশ্যই
ডক্টর রহিমুল্লাহ প্লিজ ডক্টর পৃথ্বীরাজ ডক্টর রহিমুল্লাহ
স্যার ক্যান আই টেল
ইয়েস
না আপনি কে নতুন আমরা নতুন কাউকে চাচ্ছি ডক্টর জিতেন্দ্র প্রসাদ দেখি নতুন কেউ কিছু বলুক এই তিনজন থেকে একজন Dr. Jitendra, Dr. Prithviraj, Dr. Rahimullah.
Assalamualaikum, sir.
Who is this? Who is this, please?
Sir, Dr. Prithviraj.
Okay, Prithviraj.
Sir, Assalamualaikum. Thank you, Hassan bhai. Sir, the rhythm is sinus.
Yes. Okay. Rate I have given 58 beats per minute.
Yes, sir. It is sinus and bradycardia, sinus bradycardia, and yes. There is a long QT, sir, most likely.
Well, QT it's difficult to measure it, but it was not long because you don't see the grid. PR interval is normal, QRS duration normal, QRSX is normal. Is there anything else there that? How about the QRS complex?
Sir, there is a
Look at lead 2, 3 AVF.
3 and AVF, there is slight 3 are ecto ST depression.
Well, it's almost isoelectric, right?
Isoelectric.
And but the key wave is flat. What else? Okay. So I have magnified.
Sir, Dr. Saurabh Das next. Okay, Dr. Saurabh Das, please try your luck. Dr. Saurabh Das.
Sir, it's.
What is it?
Sir, hypokalemia hote pare sir. Hypokalemia ECG.
But there is no E wave.
No.
No, I'm talking about the QRS complex.
Sir, Qrs Complex is narrow. There is Q wave in 2, 3 AVF.
Yes. And why do we have a Q wave there?
Sir, possibly old inferior MI.
Okay, good. So that's what I was looking for. That you see, there is a Q wave in 2, 3 AVF. Now, what is the definition of Q wave? Look at this. There is a Q wave here also, lead in V4. Is this pathological?
No, sir.
Is this pathological? Look at this. So what I did is I magnified this ECGs. So when I magnify lead 2,
pathological.
What is the definition of pathological Q wave? More than one small box.
One small.
Yes, and at least 25% of the QRS complex. Here I did not measure it, but if you look here, it is more than 25%.
Yes, sir.
So there is a Q wave in lead 2, 3 AVF, and that's consistent with old inferior myocardial infarction. Yep, thank you.
Sir, Sir, Saurabh Das ছিলেন, আপনি কি লাস্ট আনসার কি Saurabh Das দিয়েছেন?
জি স্যার।
ওকে, বিজয়ী লিস্টে আপনার নাম পেয়ে যাবেন আজকে। নেক্সট।
Thank you, sir.
Okay. And somebody else doing this one?
নতুন কেউ হলে ভালো হয়। ডাক্তার কৌশিক কি ট্রাই করবেন? ডাক্তার কৌশিক, why don't you try your luck?
Yes, thank you for giving me the chance. Thank you, sir. Good morning.
Yeah, sir. I have given the heart rate is 64. You do the rest of it.
Yeah, so rhythm is sinus.
Okay.
Because P followed by QRS, and so there is a biphasic T wave in lead 1, V1, V2, V3, V4, V5.
Okay. And whatever the QRS complex duration?
QRS, sir. 1,
yes.
2, 3. Sir, almost, sir, 120 millisecond.
Why is it wide?
So why is due to sir ventricular origins? Sir,
that's abnormal, right?
Yeah, sir.
What can make the QRS wide? Well,
due to the conduction delay.
Okay, conduction delay. So that's perfect.
Incomplete RBB is present.
120 is actually complete. Why? What is the pattern? So 120 or more is complete.
Oh, sir.
So there is M pattern in lead V1.
Yes, sir.
And there's a deep S in lead V6. So sinus rhythm with right bundle branch block. And now look at lead 2, 3 AVF. What do you see in 2, 3 AVF?
So, yes, to 2, 3 AVF, there is a M pattern, sir, in QRS complex.
No. And look carefully. What is the first complex in 2? Is it positive or negative?
Sir, lead 2.
Yes, lead 2. What is this?
Q.
Q,
Positive,
yes.
lead 2.
No.
Q is
First
the answer.
complex of the Q. And how about 3? Lead 3, there is a Q wave, right?
Yes, sir.
How about lead AVF?
Q present.
Q wave present. What
Sir,
is the definition? Definition of Q wave is
more than one small square.
No. Definition of Q wave is a negative complex not preceded by a R wave.
Okay.
So like in lead V6, there is a negative, but there is an R wave before that. That's not a Q wave. In 2,3 AVF, there is no sign. I expanded that again. So for your clarification, look at this. It is one box, that is 40 milliseconds. In 3, it is bigger than one box. It's 1.5 box.
Yes, sir.
And it's almost like the height of R wave, and then look at lead AVF. So that's the pathological Q wave. Why do we have a Q wave in 2,3 AVF? What is the final diagnosis?
So final diagnosis, sir, old inferior MI.
Yes. You have to tell sinus rhythm, right bundle branch block, and old inferior myocardial infarction. Okay, thank you. So I'm going to skip this one. We don't need to do this. We'll come later on. So there is another condition that we see sometimes patient will come to the hospital with chest pain, and then we'll have this diffuse ST elevation. I mean, it's tough. If you look at it, it looks almost like convex, but there is a difference in pattern. It looks like concave mostly, and it's everywhere. And this is a patient that can cause us problem, because if we don't diagnose it properly, we can run into trouble. So what problem? If it is acute myocardial infarction and we don't give heparin, we may kill the patient. If it is a condition called pericarditis, and if we give heparin, we can cause pericardial tamponade. So that diagnosis is very, very important. So when we see an ECG like this, concave ST elevation, diffuse, it looks like pericarditis. And then one of the tests that you can do is one is get troponin, but troponin can be slightly elevated in pericarditis. One other test is very good to do is do an echocardiogram. And if we do an echocardiogram, if there is no regional wall motion abnormality, this is definitely pericarditis. And finally, I mean, if we still have confusion, we can do an angiogram without giving heparin to prove that it is pericarditis. What happens with pericarditis? Widespread concave ST segment elevation with PR segment depression in multiple leads, reciprocal ST depression and PR elevation in lead AVR and V1, and downsloping TP segment. That's difficult to see. So let's look at it. If you look at this one, it's a concave ST elevation, and there is a PR segment depression in lead 2, which is, and slightly in lead AVF. So the PR segment depression is something that helps us in diagnosing. So this is one of my patients that came with epigastric pain, and this was done, ECG was done on 7th of November, 2013. And nothing really much except the diffuse T wave flattening. There is T inversion in lead 1, AVL. And nobody paid much attention to this thing. Next day, this is 7th. Next day, patient developed ST elevation in lead 2, 3, AVF, V4, V5, V6. And this is previous old ECG. We didn't have those changes. So clearly there is acute ST elevation. But what we looked at first ECG that on the 7th, nobody paid attention. But if we draw a line, you can see there is PR segment depression. This is one of the earliest signs of pericarditis. So this is very, very important that we have the reflex of just, oh, I looked at an ECG, everything looks fine. So always try to find an old ECG to compare. That may give you a clue, like in this patient, the day 1, I'm going to go back this ECG showed ST elevation. The day before, there was PR segment depression and slight PR elevation in lead AVR. So this is pericarditis. So what we see in pericarditis, that ST elevation, PR depression except in one AVR, and ST depression in AVR and V1. Those are the findings of pericarditis. Give this one. Okay, so this is a patient who had actually a bypass surgery. So this is the ECG done on January 13, 2006, and then January 19, more or less similar ECG. But if you look at January 19, later in the day, there is ST elevation in lead 2, 3, AVF, V4, V5, V6, but that's a diffuse ST elevation. And again, this is a patient who underwent bypass surgery and developed postoperative pericarditis and diffuse ST elevation. This is another one, but this ECG is very confusing. It looks almost like ischemic ST elevation, but again, this was again another patient, the 41-year-old male with ST elevation. And this kind of ECG, of course, will prompt what the clue is that there is PR segment depression here, but still this is a very tough ECG. This is very close to acute MI. We have to make sure that this is an acute MI. This is a case of pericarditis. I'm going to stop here and then we'll take any question from the audience.
Dr. Saifur Rahman, do you want to ask anything? MD Saifur Rahman, please. Dr. Saifur Rahman?
I think the main goal of this today's talk will be to identify acute myocardial infarction. And then another condition is pericarditis, which come with a similar symptom to acute myocardial infarction, and to differentiate between those. Please remember, acute myocardial infarction onset will be very short onset. Pericarditis sometimes can have chest pain for 2 or 3 days, and there is some positional change in the chest pain. So that's one clinical differentiating point. Patient with pericarditis will be more hemodynamically stable than a patient with acute myocardial infarction. But the distinction is very, very important because the treatment modality is different. And inappropriate treatment of any one of those will lead to problem. Just as I mentioned, if you give heparin to pericarditis, you will develop pericardial effusion and tamponade. And if you do not give heparin in myocardial infarction, it can make the patient's condition very worse. And it's always a good idea to show this ECG to second person. Even at my age, at my experience, we talk to each other. It always helps. It always helps. I know that there is a little bit of tendency in Bangladesh not to talk to people. When you ask somebody something, doesn't mean that you don't know about it. You are just trying to validate your finding. Hey, what do you think? Have you ever seen something like this? It can be somebody, you show it to a senior, sometimes you show it to your colleague, and we show it even doctors younger than us. Please remember that younger doctors come with a fresh brain. They may have seen something that I have not seen, and they can give me some help in any clinical scenario.
Dr. Jayan Hussain, do you have any question? Dr. Zayan? Okay, please.
Thank you, sir. স্যার আমার প্রশ্ন হচ্ছে যে কারো যদি স্যার বান্ডেল ব্রাঞ্চ ব্লক থাকে অথবা কারো যখন পেসমেকার লাগানো থাকে ওই সেটাবে স্যার আমরা অ্যাকিউট এমআই ডায়াগনোস করাটা আমাদের জন্য খুব কঠিন হয়ে যাচ্ছে তো এটার ব্যাপারে যদি এক্স দিতেন স্যার আমাদেরকে
Okay, if it is right bundle branch block, it will show the ST segment change just like any other patient, because the right bundle branch block, the abnormality in lead V1 and V2 only. Other leads will show ST. It is left bundle branch block that creates a problem. And for the left bundle branch block, I showed you the ECG that if in let me go back. This is the left bundle branch block pattern, and there is more than 5 millimeter ST elevation in lead V2, or in V5, V6, if there is more than 1 millimeter ST elevation, and that's acute MI. Pacemaker ECG will become a major problem. Sometimes you may have extreme difficulty, so you'll have to go by clinical scenario and your troponin. And if there is any reason to believe, you should just do a cardiac catheterization on those patients.
Thank you, sir.
Thank you.
Sir, I have a question.
Yes, go ahead.
After Purichoy, please.
Dr. Mason Pradhan.
Okay. Please.
Sir, what is the finding in ECG in subendocardial MI?
Well, subendocardial MI, we don't use that term anymore. We use non-ST elevation myocardial infarction. So basically, that can range from even a perfectly normal ECG or ST segment patient having chest pain, and the troponin is elevated. And that is not ST elevation myocardial infarction. And most of them will have some ST segment change. So that will be the definition. Subendocardial is the old term that we used. We don't use that anymore. And the reason we don't use it, if you look at the myocardium, if you have a conical segment of myocardium that is ischemic extending to the epicardium, that's almost a transmural infarct, but it does not show the acute ST elevation. So that's why the subendocardial term is no longer used.
Thank you, sir. আমরা শেষ করে দেই স্যার, তাহলে আপনি স্যার আপনার কোনো কনক্লুশন রিমার্ক থাকলে দিবেন, তারপর চেয়ারপারসন স্যার শেষ করবেন।
I would like everybody to participate more, please. Remember that you can answer anything. The whole point is that the more we discuss, the more we learn. So please participate. I would encourage everybody to participate in this and answer questions. And of course, you get the prize also. Next week, shall we do supraventricular tachycardia?
I think it's okay, sir.
Okay, good. And then week after that, we'll do white Qrs tachycardia. Thank you.
স্যার, তাহলে আমি আজকের 5 জনের নাম স্যার আমি আপনাকে একটু পড়ে শোনাই, আপনারা যদি এখানে কোনো কাটছাট করেন করতে পারেন। স্যার, ডাক্তার মাহবুবা, ডাক্তার আরাফাত, ডাক্তার মাহিম ইব্রাহিম, ডাক্তার আফসানা রহমান, ডাক্তার সৌরভ দাস।
Good, yeah, I think perfect.
তাহলে এই 5 জন যারা আছেন তারা সবাই প্লিজ আপনাদের অ্যাড্রেস এবং পিকচার আমাকে ইনবক্স করবেন, আমরা গ্রুপে এ করব। তাহলে স্যার আমরা আজকে কনক্লুশনের জন্য আমাদের আজকে চেয়ারপারসন প্রফেসর মাহমুদ হাসান স্যারকে আহ্বান জানাচ্ছি।
আমি ধন্যবাদ ডক্টর এহসানুজ্জামান সাহেব, আপনাকে এটা বিডি ফিজিশিয়ানস এর পক্ষ থেকে অর্গানাইজ করার জন্য। আমি মনে করি এটা অত্যন্ত হেল্পফুল, এই সিরিজ অফ লেকচারস অন ইসিজি ইন্টারপ্রিটেশন অত্যন্ত হেল্পফুল, এবং ডক্টর রফিক আহমদ সাহেব ইজ দি বেস্ট পারসন সুটেড ফর দিস। যে উনি অত্যন্ত সুন্দর এক্সাম্পল সহ পরিষ্কারভাবে বুঝিয়ে দেওয়ার চেষ্টা করছেন, এবং ইন্টারাকশনে আমার মনে হয় যে সবার আরো বেনিফিট হচ্ছে। তো আমি রফিক আহমদ সাহেব সম্পর্কে আমরা আগেও আলোচনা করেছি, উনি আমেরিকায় কাজ করলেও বাংলাদেশ সম্পর্কে ওনার যথেষ্ট অনুভূতি, আগ্রহ এবং সমবেদনা আছে। উনি বাংলাদেশের জন্য অনেক করেছেন, আপনারা আগেও শুনেছেন। উনি বাংলাদেশে ইলেকট্রোফিজিওলজি ট্রেনিং দিয়ে এইখানে শুরু করেছেন, না হলে আমরা হয়তো এতদিনে ইলেকট্রোফিজিওলজি পেতে দেরি হতো। তারপরে উনি বাংলাদেশে প্রায়ই আসেন, এবং উনি বিসিপিএস এ অ্যাডভান্সড কার্ডিয়াক সাপোর্ট, লাইফ সাপোর্ট এটা সেট আপ করেছেন, এবং বেসিক লাইফ সাপোর্টেও যাতে শুরু হয় সেটার জন্য উনি তো অনেক মূল্যবান যন্ত্রপাতিও উনি দান করেছেন বিভিন্ন জায়গায় বিসিপিএস সহ। তো আমি ওনার কাছে কৃতজ্ঞতা জানাচ্ছি যে উনি ওনার মূল্যবান সময় ব্যয় করে আমাদেরকে, আমাদের যারা ডাক্তার রয়েছেন যারা শিখছেন তাদেরকে এটা শিখতে সাহায্য করছেন। আমি অত্যন্ত কৃতজ্ঞ এবং ধন্যবাদ জানাচ্ছি, এবং আগামীতে আবার তার কাছ থেকে আমরা শেখার আশা জানিয়ে আমি শেষ করছি। ধন্যবাদ।
Thank you. Thank you. Yes, Assalamu alaikum.
আসসালামু আলাইকুম।
ভাই আপনাকে একটু আনমিউট করতে হবে।
মাহমুদ হাসান স্যার, থ্যাংক ইউ। ইনশাআল্লাহ নেক্সট ফ্রাইডে আবার দেখা হবে স্যার। অনেক লাইভ ক্লোজ করে ফেলো। হ্যাঁ,
থ্যাংক ইউ।